We're really delighted to have you here today in our beautiful pink cube. We call this the heart of Women's College Hospital, and this is our Gratitude Tea event because we truly are grateful for all of the support that you've provided to Women's College over the years as dedicated supporters. You're part of an extraordinary community of donors and advocates who care very deeply about the work that's done at Women's College Hospital. And even more, you care about health care for women throughout this country and health care for all. Your generosity and your partnership are what make the work possible in this beautiful facility, and we're profoundly grateful to you for that. In addition to bringing you together to get to know you better, we wanted to give you the opportunity to learn more about the work that's being done here in the hospital. As you may know, Women's College is a world leader in the field of women's cancers, particularly when it comes to research, developing innovative models of care, survivorship care, and educating and empowering women and their care providers to give better care. With a commitment to healthcare equity and access at the core of our values and our strategic mission at Women's College, it's incredibly important to us to share the impact of this work with women well beyond the walls of this building. That's why this past year, we were very proud to announce a new partnership with the Canadian Cancer Society to help our work reach families across this country. Made possible through a joint gift from philanthropist Peter Gilgan and the Canadian Cancer Society, the Peter Gilgan Centre for Women's Cancers has a bold vision to transform women's cancers nationwide. And achieving that vision starts right here at Women's College through the work that you help to support. Today we wanted to introduce you to some of our incredible leaders who are working hard to advance care and research for women's cancers, and also to a patient who credits these people with helping to save her life. Shortly you'll be hearing from, and I'm going to read this one very carefully, Dr. Kelly Metcalf, adjunct scientist with Women's College Research Institute and a world leader in the field of breast cancer research. Dr. Trulin Sill, a surgeon at Women's College who specializes in breast cancer-related surgeries. And Kirby Silverberg, a patient who has benefited from the expertise and care of both Dr. Metcalf and Dr. Sill. So please join me in welcoming Dr. Kelly Metcalf.
Thank you so much for that introduction, and thank you for coming today. And I'm always so thrilled to be able to share what amazing research that we're doing here at Women's College and the impact that this research is having on patients' lives. And for me, that's why I do it. And to see Kirby here today and to know that we were able to help her to ensure that she will be here for her children is the reason that I do what I do. So, without getting me all teary-eyed to begin with, today I'm going to talk a little bit about a study that we're doing here at Women's College that I think will revolutionize the way that women with breast cancer are treated in the future, and I hope that we will be able to take this to all women who are diagnosed with breast cancer. So I'm going to talk a little bit about the breast cancer genes BRCA1 and BRCA2, and I'm sure that most of you have heard about these genes because of Angelina Jolie's story, and that she really brought this out to the forefront about what it meant for her, the family history of cancer that she had, and then the difficult decisions she had to make when she was told she was at a very high risk of developing cancer. And although it really took a celebrity to come out with her story, I think she has brought incredible attention to the idea of BRCA1 or 2 and has enabled women to feel empowered to come forward for this type of testing because it isn't always an easy decision to make. So I'd just like to take a step backward and just to provide a little bit of information about BRCA1 and 2 and the impact that this has on the number of cancers that are developing in women who are at high risk. So you can see here from the slide, and I have it on both sides here, that the majority of cancers that are diagnosed are not due to BRCA1 or BRCA2. So it isn't something, BRCA1 or 2 are genes that are passed down from generation to generation. So you often see families with multiple cancers in the family from generation to generation to generation. But the majority of cancers are not due to these genetic mutations. In fact, the majority are what we call sporadic breast cancer. So that's 90% that are really not due to these generations of genetic mutations being passed on. So there are two main breast cancer genes that were discovered in the mid-1990s, and they are BRCA1 and BRCA2. And since that genetic discovery back in the 90s, we have then been able to offer this type of genetic testing at a clinical level so that women who are at high risk of developing cancer can have this genetic test to see if they have a mutation in either BRCA1 or BRCA2. So we see these women in our clinics, and we do have clinic here at Women's College where we see women and men who are interested in knowing whether or not they have a BRCA1 or BRCA2 mutation. And when we do see these women in our clinic, we're then able to tell them if in fact they are at high risk of going on to develop breast or ovarian cancer, or if they are in fact at a risk that the average woman would have in the population. So if we do see a woman and we do a genetic test, it's often done as a blood test, we're able to give these women genetic information. So we are able to predict who may get breast cancer and who may get ovarian cancer. If they're told that they have a BRCA1 or 2 mutation, you can see that they have very high lifetime risks of going on to develop breast cancer. So for a woman with a BRCA1 or BRCA2 mutation, she has over an 80% lifetime risk of developing breast cancer. And this is very, very high. And this can be compared to the woman in the general population, where her risk is about 11 or 12% of going on to develop breast cancer. Also for these women, if they do develop an initial breast cancer, they have a very high lifetime risk of going on to develop another cancer. And this isn't just a recurrence of that first breast cancer, it's a totally new breast cancer. Again, very high lifetime risk. Ovarian cancer, again, something we're very concerned about in these women. For breast cancer, we have very good screening. All of these women are eligible for breast MRI, and we know that that type of imaging is far more effective for these young women compared to our standard mammography. The problem with ovarian cancer is we don't have good screening, and we can't pick these cancers up early, and they're often diagnosed at a very late stage where the chance of curing that ovarian cancer is very low. So a big concern of ours as clinicians and as scientists, and it is this ovarian cancer risk for these women. And you can see this is up to 60% compared to the average risk of just over 1% for the average woman. So all of these risk estimates for cancer are things that we talk about with women who we see in our clinic who are told that they have a BRCA1 or BRCA2 mutation. Not only do they have high lifetime risks of developing breast cancer, they're also diagnosed at a very young age. So these are often premenopausal breast cancers we're seeing being diagnosed in the 40s. So we have to think about, if we're thinking about prevention of these cancers, we have to think about preventing it at a young age. So you can see here with our BRCA1 carriers, they're diagnosed at the average age of about 42. It's slightly older for BRCA2, but this is considerably younger than what the average age of breast cancer diagnosis is for women in the general population who don't have a BRCA1 or BRCA2 mutation. So the question was then, if a woman has breast cancer and she has a BRCA1 or BRCA2 mutation, I've told you a little bit about the differences between breast and ovarian cancer in women with a BRCA1 or 2 mutation versus those in the general population. The question then is, if they do present with a breast cancer, should they receive the same treatment as women with a breast cancer that is sporadic or not due to a BRCA1 or 2 mutation? So we know for the average woman, there are surgical choices that she can make, and she talks to her surgeon about what these decisions might look like and what might be best for her. And generally, the surgical decision-making revolves around the idea of just removing the tumor and some tissue around that tumor, called a lumpectomy, which is followed by radiation. Or she may be a candidate for a mastectomy on one side, the unilateral mastectomy. So, the breast that's affected by the breast cancer is removed. Or in some cases, women may elect to have both breasts removed as part of their treatment. But what we know for women in the general population is there is no difference in survival depending on what surgical treatment she decides to have. So we didn't know if that was the case, though, for women with a BRCA1 or 2 mutation, really sparking the interest in doing research to look at this, because we need to know what to tell our patients to do to ensure that they will do their best to survive this initial diagnosis of breast cancer. So this was a study, and it's very complicated, and as scientists we present all these numbers, but I'm going to give you the gist of what it is. So this was a study we did where we had women from all over North America who had been diagnosed with breast cancer, had a BRCA1 or 2 mutation, and we followed them from the time of breast cancer diagnosis, and we followed them up to 20 years after their diagnosis. We collected all of the information on their initial breast cancer pathology, so the characteristics of the tumor. We collected all of the information on the treatments she received, and then we followed them to see if in fact there was a difference in terms of survival from those who chose one surgery versus the other. And what we found was that women who had a bilateral mastectomy, and remember, these are women with a BRCA1 or 2 mutation, those women reduced their risk of dying over 20 years by almost half. So by having a bilateral mastectomy as compared to just having one breast removed, we could reduce her risk of dying by half. So this was an incredible discovery and something that has changed clinical practice. But the problem is, and something that I saw as a scientist wanting to taking that research findings into clinical practice, is the majority of women don't know at the time of breast cancer diagnosis if they have a BRCA1 or 2 mutation. So how can they make this decision if they don't know if they have one of these mutations? So that was something that I was determined to find out. So we know that this is not the case for women with a BRCA1 or 2 mutation. There are survival advantages associated with having the more aggressive surgery or the bilateral mastectomy. So, in Ontario, there are very strict criteria for who is eligible for genetic testing for BRCA1 or 2. It mainly relies on your personal history of cancer, so how old you were when you were diagnosed with breast cancer. It relies on your family history. So how many people in your family have had breast cancer? How old were they when they were diagnosed? We also look at ethnicity because we know that certain ethnic groups have a higher frequency of having one of these mutations. And this is especially true in the Ashkenazi Jewish population, where we know women and men are much more likely to have a BRCA1 or 2 mutation compared to non-Ashkenazi Jews. So in Ontario, if you do qualify for genetic testing when you're diagnosed with breast cancer, typically you cannot get those genetic test results back prior to your surgery, which often happens within 2 to 4 weeks after a diagnosis. There is something called expedited testing that can happen, so if you're lucky enough to be referred by your surgeon for testing, you can get those results slightly quicker. However, we're very fortunate in Toronto that we have access to these genetic counseling services and testing centers, but that's not true for everyone in the province of Ontario or in fact in Canada. So this is something we wanted to look at. If we provide this kind of information to women at the time of their breast cancer diagnosis, what do they do with that information? So do they change their surgical decision making, and do they go for a surgery that we know is going to reduce their risk of dying by half? So we were very fortunate to receive research funding to look at this particular question. So we were interested, and this is called the Rapid Genetic Testing Study. We're running it here out of Women's College Hospital, but we're not only recruiting women from Women's College any woman, well, there are criteria, but women diagnosed with breast cancer at Sunnybrook, Princess Margaret, St. Mike's, and Women's College. And we're following these women to see what do they do, what do they choose in terms of their surgery decisions, their medical decisions. But I was not only concerned about that, I also wanted to know, if we provide genetic testing at the time of breast cancer diagnosis, are we causing more distress to a woman by giving her this information? Because we already know that this is a very stressful time for the majority of women at the time of breast cancer diagnosis. So did it make sense to offer this testing at this time of diagnosis, or should we wait until after she's gotten over her breast cancer diagnosis? So that was something that we're also measuring in this study. So what happened? Initially, a woman is diagnosed with breast cancer. She's told by her surgeon that she has breast cancer. And that woman, if she is agreeable, is referred into our study and is seen by a genetic counselor or contacted within 24 hours. And these women come to see us. They have genetic counseling, and we take a blood sample. And we're then able to offer, because of this new genetic technology that we have here at Women's College, we're able to offer this genetic test result back in 10 business days. So she gets the results very quickly prior to her surgery, and she's able to take that genetic information and make a very informed decision about what she wants to do in terms of surgery, taking into consideration this genetic information. We then follow the women after we give her her results. We're again looking at the psychosocial functioning. What did she think of this? Was it too much to handle at the time of breast cancer diagnosis? So I'm going to present to you some of the results of this study so far. We are going to be testing 1,000 women in this study. We're almost there, and I'm very sad this study will be over soon, and we only have funding to be able to do this for 1,000 women. So we have tested almost 840 women, and you can see, as expected, sorry, I keep hitting the wrong button. As expected, the majority of women do not have a BRCA1 or 2 mutation, but this is the important line here. 6.2% of women have been positive in this study. So 52 women. What's interesting is not all of these women would have been eligible for genetic testing based on the Ministry of Health criteria. So we would have missed women who we could have given this genetic information to and had an impact on survival. And more surprising, and I think a little bit concerning for me as a researcher, is that 9 women, so 17% of these women, were actually eligible for genetic testing before they even got breast cancer. So if we had done genetic testing prior to breast cancer diagnosis, we could have done something to prevent those cancers from ever happening. So this is something we need to do about. We need to educate our healthcare providers still. We need to educate women and men like you to know whether or not they need to have genetic testing and if they want to know that type of information. So what did women do with this information? Because it's not of value to be offering genetic testing at the time of breast cancer diagnosis if women don't take that information and change their decisions to have an impact on survival. So you can see here, this is women who had a BRCA1 or 2 mutation, so positive, versus those who are negative. You can see that 84% of women who had a BRCA mutation chose to have a bilateral mastectomy, compared to less than 17% of women who had a negative result. And this shows that genetic testing is having an impact on women's surgical decision making, and we are going to be able to save lives because of that. So what about psychosocial functioning? As someone who has an undergrad in nursing, it's something that I'm concerned about. I want to know, are we causing more distress to these women by offering genetic testing? What you can see here in the graph is those are in red. This is distress related to their cancer diagnosis. So those in red had a negative BRCA result. Those in blue had a positive. And you can see there is no significant difference between distress at any time point that we measured. So we followed them time of genetic testing 1 week after they got their results and 1 year after they got their genetic test results. And you can really see it's just a function of time of that distress going down. So every woman with breast cancer has that distress. The majority, the distress is high. But after, it does go down over time, and it has nothing to do with whether or not they were positive or negative, really suggesting to us that adding that genetic testing at the time of breast cancer diagnosis is not having a negative impact on psychosocial functioning in these women. And what about satisfaction? So this is a very fast way of delivering genetic testing. We want to get them in, get them tested, and get them the results. And at a time where they're already having all of their staging for breast cancer, they may be starting on some of their treatments. So what you can see here, though, is the majority of women were somewhat satisfied or very satisfied with the entire process. Again, suggesting that this is a very effective and beneficial program for women diagnosed with breast cancer. The problem is, like I said, most women don't know if they have a breast cancer diagnosis, and we did have criteria for this study. It wasn't as strict as the Ministry of Health criteria for testing. It was slightly relaxed, but it didn't include every woman with breast cancer. And at Women's College, we do think every woman with breast cancer and every Canadian, regardless of whether or not you've had a diagnosis of cancer, should be able to have genetic testing if you want it. And we not only want you to have the availability of this genetic testing, but that as healthcare professionals, we can follow you to ensure that you're receiving appropriate care after you receive your genetic test results. So we are doing a project at Women's College called the Screen Project, where we are planning on testing 10,000 Canadians for BRCA1 and BRCA2 mutations. This test generally isn't available to everyone within the province of Ontario. You can have your genetic testing done through various labs in the US, but it's very costly. It ranges between about $500 and $2,000 to get this genetic test result done. So we are able to offer this at a very reduced price because we want it to be accessible to women, and we do have financial help available for people who can't afford to have this test, because we do think it's important not only for cancer treatment that I've talked about today, but cancer prevention. And you'll hear from Kirby later about the importance of preventing these cancers before they ever happen, because we can do that. Knowing this genetic information, we can prevent both breast and ovarian cancers from happening in these high-risk women. So like I said, this is the Screen Project. It's available to anyone. You can go online, you fill out a small questionnaire, and we actually just mail you tubes that you spit into, and we take your DNA and we run it for BRCA1 or 2, and we then disclose those genetic test results to you and follow you if you do have a positive result to help you make these decisions about prevention. And we have begun to get results back. We are finding people with BRCA1 or 2 mutations that had no family history of cancer at all. We are able then to not only test the person who's come forward, but once we identify a BRCA1 or 2 mutation in one individual in a family, we can then test all of his or her blood relatives for that exact same mutation. So it does end up benefiting the entire family if people want to know that information. So you can go online. It's called thescreenproject.ca or .com, I can't remember. But if you just Google it, as my kids say, just search it up. Anyway, so I just want to end by saying all of the treatment and the care that you receive at any institution that you go on hopefully relies on research that informs what we are doing as clinicians for your care. And I think at Women's, we are very committed to that in the area of women's cancers. We are devoted. We have a very successful research team here at Women's, especially in the area of breast and ovarian cancers. And we aim to take our research findings and translate it to clinical practice. And we're very involved with the surgeons and clinicians to be able to do this kind of research and make sure that the research that we do gets back to the patient, because that's ultimately the person who benefits from all of the research that we do. So I'll just end there, and I'm acknowledging all of the wonderful people that have helped with this study and making it the success that it is. And we will come to an end, and it's unfortunate that we've received funding for just the 1,000 people from the Canadian Institutes of Health Research to do this study. But we will be lobbying government and policymakers to see how we can better integrate genetic testing into the breast cancer diagnosis so that women can benefit from this research. So that's where I'll end, and Dr. Sill, I guess you're up next. Thank you.
Okay, well, thanks very much, Dr. Metcalf. That's a hard act to follow. So I'm Dr. Tillensill. I am a breast cancer surgeon. I work here at Women's College Hospital as well as Princess Margaret. You can't hear me? Okay, I will speak a bit louder. And over the next few minutes, I just want to give you an overview of some of the things that we do at Women's College in terms of treatment and prevention of breast cancer from a clinical aspect, some of the research that we do, and the education that we also provide to patients and trainees. So to start, I'm going to talk a little bit about the clinical aspects of breast cancer. This is the Edwin Smith Papyrus, and we know that breast cancer is an ancient disease, and it's actually depicted in this very old surgical manuscript where there was a description of 8 cases that were consistent with breast cancer. So we know breast cancer has been around for a very long time. And we know that many women will be affected by breast cancer in their lifetime. So in Canada, 1 in 9. The types of breast cancer can be quite different for each individual patient. We may see breast cancers that arise in the milk ducts. Some of them arise in the glands that make the milk, so lobular cancers. We see tumors that are quite early thanks to the screening programs that we have with mammograms finding disease at a very early stage. But we also see cancers that are larger, particularly in younger women who don't undergo screening. So some of these cancers are already involving lymph nodes, others involving skin. And so how we approach the surgery and the treatment for breast cancer is different for each individual patient. And so historically, the surgical options were quite limited, and this is depicted in some of the artwork that we see. William Halsted was one of the fathers of breast cancer surgery, and so back at the turn of the century, he proposed that breast cancer should be treated very aggressively and all tissue removed. And while this did cure some women, it left them with obvious physical and psychological sequelae of treatment. But now we can really provide treatment that minimizes the tissue that we remove, and it leaves the breast as in terms of its more natural appearance, and I think minimizes the psychological impact of treatment of this disease. So when we remove all of the breast tissue and the lymph nodes under the arm, this was a historic traditional approach to really all breast cancers. But today, because we're finding tumors quite early, we can offer women a lumpectomy. So we just remove the tumor with a healthy margin of breast tissue around it. Breast cancer can spread outside the breast, and it goes to the lymph nodes in the armpit area as one of the first areas that we think about for metastasis. And historically, we would have to remove the whole group of these lymph nodes, but we know now that this doesn't have to be done for most patients, and we have techniques to minimize how many lymph nodes we take out. The problem with taking out a lot of lymph nodes is it leaves women about a third of the time with arm swelling or lymphedema, which can be very, very symptomatic and hard to manage over the long term. So all breast cancer patients have a unique situation. They can present in different ways, and our job as clinicians is to really take what we know about their disease and offer the best treatment for them on a personalized level. So what's good for one patient is not necessarily good for another. And so what we do is work as a team, and you've already heard from Dr. Metcalf about the genetic aspect of it. But I work with wonderful colleagues in radiology who diagnose these tumors on imaging, pathology, and they give us the diagnosis. Other surgeons, including our reconstructive surgeons, as well as our other colleagues in medical and radiation oncology. So we're able to offer women treatment and then move forward with adjuvant therapy and then survivorship, where we teach them about the long-term aspects of trying to reduce recurrence. So as Dr. Metcalf mentioned, most breast cancers are not genetically linked, but 10 to 15% are. And it's those breast cancers that we would hope to try to prevent and reduce the risk for. So two of the most commonly known genes, as you've heard, are BRCA1 and 2. And this was really brought to the forefront when Angelina Jolie talked about her experience with BRCA1 and 2. You see, this was the day, I think, that the editorial came out, and we know that a tremendous number of people accessed this and found out more about breast cancer in that day. So in terms of the things that we can offer women for reducing the risk of breast cancer, we can perform mastectomies by sparing all of the skin, and we can also now spare the nipple and the areola. And so these are called skin sparing and nipple sparing mastectomy. And we can also reconstruct the breast at the same time. So this is done in conjunction with our plastic surgeons. And this is one way of doing breast reconstruction. And this is using an implant where first an expander is inserted, and then over time it's inflated, and then the final surgery exchanges the expander for the implant, and women have their final reconstruction. We can offer more innovative techniques, though, of reconstruction, and this is just one example. This is using a material called alloderm, which allows the plastic surgeon to actually do the entire reconstruction at the same time as the mastectomy, so hopefully avoiding a second surgery for these patients, which we hope would improve their quality of life. So I'm going to switch gears for a second and talk about research, and you've already heard about some of the fantastic research that goes on in our institution. What I'm interested in from the breast cancer perspective is outcomes and how women do after surgery. And we have access to a population-based level research database from the American College of Surgeons. There are several hundred institutes that submit data, and we're able to look at this data in terms of looking at complications after surgery, all surgeries, but in particular, breast surgery. So this is some of the research that our group has done. So one of the studies we looked at was looking at the complications associated with removing one breast versus two breasts when we're talking about breast cancer treatment. And we could look at the particular complications associated with doing more surgery and then what that meant for the patient. This study looked at those complications in light of metastatic disease. So what if women had distant metastasis in the bone or other organs and then underwent surgery? What would be their outcomes? So we saw that there was slightly higher risk of surgical complications. This is another example of when women undergo chemotherapy before their surgery. How does it impact on their surgery outcomes? And we saw that really having chemotherapy before didn't increase the risk of complications with their breast surgery after. So I work with a lot of colleagues here, and one of these folks is Dr. John Semple. Some of you may know. He's an outstanding plastic surgeon, and he's done some very innovative research on looking at mobile innovation. So they've developed an app on the mobile phone that allows a patient after surgery to correspond to their surgeon by uploading information about how they're feeling, by uploading pictures of their incision and surgical site. And they've really published this innovative research in a major journal. And it really shows us that patients can benefit from this kind of in-home monitoring. And this is particularly relevant to us because we're an ambulatory hospital, so patients go home the same day. But with this kind of technology, they can still be followed when they're home. So breast cancer surgery involves more than just the surgeon, of course. There's a whole team, and part of that team is anesthesia. And my anesthesia colleagues also really push the forefront of innovation and different things we can do. And this study was part of our program of offering patients blocks. So similar to when women would get an epidural for childbirth, we could do a block, meaning putting local anesthesia in the area of the breast and underarm before surgery. And we found that this really improves their outcomes both during the operation and after the operation in terms of pain control. I'm going to touch on Ruby, which is a multi-center study, and Women's College is one of the two main sites that's hosting this study. We know, unfortunately, that about 5.5% of women with breast cancer are under 40, and this is a population that we don't catch with screening because they're young, and it's not many cases at each center, thankfully. But then it's hard to find out about the long-term outcomes for these women. And so the Ruby study really aims to look at the long-term outcomes by putting together data from multiple sites across Canada. And so this is one of the studies that our center is involved in. So my last aspect is education. I'm just going to touch on this briefly. And this is close to my heart because I do education research as well. But patient education is an area I think we can continue to improve and grow. And so what our group did was come together with the interactive perioperative education team at UHN and developed a patient education video about some of the procedures we do. And so I'll just give you a quick glance at it.
A mastectomy is a surgical procedure to remove the breast tissue. Women who have been diagnosed with breast cancer may consider a mastectomy as the main treatment option. This is called therapeutic surgery. Patients with a high risk of breast cancer may also decide to have a mastectomy to prevent breast cancer from developing. This type of surgery is termed risk reduction surgery, but is also called prophylactic surgery. There are several different ways in which a mastectomy may be performed. As each patient's situation is unique, it is important to talk to your doctor regarding the surgery options and the risks. If you are considering a skin-sparing mastectomy or a nipple-sparing mastectomy, this video is to help you understand the two procedures and make a decision about which operation is best for you. The anatomy of the breast. On the outside, the breast is made up of the skin, the nipple, and the areola. On the inside, the breast is made up of different tissues, including lobules that make milk, ducts which carry the milk to the nipple, supporting cells called stroma, as well as fat. The breast tissue lies on top of the pectoralis muscle. There are also a number of lymph nodes in areas around the breast and lymph vessels within the breast tissue. These are an important part of the immune system. What is a skin-sparing and a nipple-sparing mastectomy? These two procedures can be compared to a simple mastectomy procedure. A simple mastectomy removes the breast tissue along with much of the skin, the nipple, and the areola. A skin-sparing mastectomy removes the breast tissue, the nipple, and the areola while preserving most of the breast skin. A nipple-sparing mastectomy removes the breast tissue but preserves the skin, the nipple, and the areola. With a simple mastectomy, breast reconstruction is done in a separate procedure sometime later. With both skin-sparing mastectomy and nipple-sparing mastectomy, breast reconstruction can be done at the same time as the mastectomy procedure immediately after the breast tissue is removed. Both skin-sparing mastectomy and nipple-sparing mastectomy result in a more natural-looking breast reconstruction compared to a simple mastectomy. Patients who undergo a skin-sparing mastectomy have the option to reconstruct the nipple and areola in a separate procedure later on. What do I need to consider when deciding between a skin-sparing or a nipple-sparing mastectomy? Eligibility. Not everyone is a good candidate for both procedures. A nipple-sparing mastectomy works best for women that have a smaller breast size and no significant breast droop. A nipple-sparing mastectomy is not usually recommended in the treatment of breast cancer for some patients, such as those with higher stage tumors, or in cases where tumors and/or calcifications are too close to the nipple. Cosmetic outcome. Preserving the nipple and areola generally results in a better cosmetic outcome. The breast reconstruction most closely resembles the patient's body before the procedure. Cancer risks. Surgery provides a significant reduction of the risk of cancer. In a nipple-sparing mastectomy, although additional breast tissue is left behind along with the nipple and areola, there is limited data regarding whether leaving this extra breast tissue is related to an increased long-term cancer risk. What happens during a skin-sparing or nipple-sparing procedure? What happens before surgery? Do not eat or drink after midnight on the night before your surgery. You will check into the hospital on the morning of the surgery. Prior to the surgery, your plastic surgeon will draw out landmarks and the incisions with a marking pen. What happens during surgery? Once in the operating room, you will be lying down on an operating table and given a general anesthesia, put to sleep. If you have decided to have immediate breast reconstruction following the mastectomy, there will be 2 surgeons and teams that take part in the surgery: the breast surgeon who removes the breast tissue and the plastic surgeon who reconstructs the breast. The breast surgeon will start to remove the breast tissue. In a skin-sparing mastectomy, the incision will be an ellipse that goes around the nipple and areola. The skin flaps will be raised. The breast tissue will be separated from the skin until the edges of the breast are reached. The breast tissue, along with a portion of skin, the nipple, and areola, is then removed from the pectoralis muscle in one piece. In a nipple-sparing mastectomy, the incision may be around the lower portion of the nipple, with a line out to the side, like a spoon, or under the breast at the crease that is hidden. During the tissue removal, no skin is removed, and the nipple and areola are left intact with approximately 5 to 10 millimeters of tissue left behind. Your surgeon may take a separate biopsy of tissue from directly behind the nipple in order to test it for abnormal or cancer cells. What happens during the breast reconstruction? Based on the reason for surgery, body type, and personal preference, there are a variety of different options for reconstruction, including insertion of a tissue expander, or implant, or using a tissue flap from another part of your body such as the belly, or back. In this video, we will show reconstruction using the insertion of a tissue expander. Once the breast tissue has been removed by your breast surgeon, your plastic surgeon will start the reconstruction of the breast by placing a tissue expander under the pectoralis muscle. A tissue expander is an implant that is like a balloon. Over several weeks, the skin and muscle is stretched to make room for the final implant. A skin-sparing or nipple-sparing mastectomy with reconstruction usually takes 2 to 4 hours to complete. What happens when I wake up? When you wake from surgery, you will be in the recovery room where your pain will be managed by medication. There will be plastic drainage tubes that collect fluid from the space under the breast skin. These tubes are connected to a drainage bulb and will remain in place for approximately 5 to 10 days after your surgery. They will be removed by your home care nurse or doctor after that. What will happen after surgery? What should I know for home recovery? For some procedures, you can go home the same day as your surgery. In others, you go home the next day. You may have some nausea right after the operation, and you should expect to have some pain. These symptoms can be managed by medications and will subside. You should return to your usual activities soon after surgery. However, you should refrain from lifting anything over 10 pounds for a period of 4 weeks. There will be exercises you are instructed to do in order to maintain your arm mobility and range of motion. What should I watch out for? Most complications are seen soon after surgery while you are in hospital, but some may happen after you have gone home. You must contact your surgical team or go to the nearest emergency room if you have any of the following signs and symptoms: fever, over 38 degrees Celsius or 100 degrees Fahrenheit, redness or excessive swelling around the incision, pus or pus-like discharge from the wound or in the drainage tube, uncontrolled pain. What are the risks and complications? As with any surgical procedure, there are risks involved. Most complications are temporary and reversible. Short-term complications may include bleeding and infection at the surgical site, fatigue, numbness of the skin, fluid buildup called a seroma. In some patients who have had a nipple-sparing mastectomy, there may be lack of blood supply to the nipple that causes tissue loss. This is called nipple necrosis, and about 10% of cases experience some amount of necrosis. However, it is rare to lose the entire nipple. All patients should expect permanent loss of sensation to the breast skin, nipple, and areola. Some patients should also expect to experience these long-term complications: pain or discomfort, non-cancerous nodules or lumps due to fat necrosis. What follow-up appointments will I have? You will meet with your breast surgeon about 2 weeks after your surgery to review how you are doing and to go over the pathology results. You will see your plastic surgeon as well for follow-up. Your surgeons will talk with you about the need for additional follow-up appointments. No routine imaging follow-up is needed after skin-sparing or nipple-sparing mastectomy. However, your physician should perform a routine yearly clinical breast exam following your surgery. Depending on the method used in breast reconstruction, you may require future surgery, for example, to replace implants.
So I'm going to end it there. I'd like to really thank you for all of your support, because none of this would be possible without support from folks like you. And I'm going to hand it over to Kirby.
Good afternoon. Thank you for being here today and allowing me the opportunity to speak to you. I'm honored to be here and to share with you a story, my story. I've known the horrible effects of cancer since a very young age. Growing up, very few of my friends knew what cancer was, and some of them had heard of it, others had no idea what it was. For me, it was an all too familiar word. I've witnessed many loved ones pass away due to various types of cancer. The sad reality is that nowadays, I don't think that I know anyone who cancer hasn't in some way changed their lives. Whether it was the passing of a loved one, watching someone go through endless rounds of chemo or radiation, a personal experience, it seems as though everyone knows someone who's been touched by cancer. According to a recent breast cancer statistics and study, approximately 14 people die of breast cancer in Canada every single day. That's over 5,000 women who die every single year, and that number continues to grow. On December 22nd, 2016, my sister became one of those 14 people that passed away that day. Sorry.
Do you want me to read it? I'll be your voice. Okay. She was a bright and shining light in this world, and I miss her very much. If there's any ray of hope, it's this. Losing my sister saved my own life. When Krista died, it shook our family to its core. Holding my sister's hand while she struggled to breathe, watching my mother lose a piece of herself as her firstborn. Oh no, this is a mess. Watching my sister lose a piece of herself as her firstborn child took her last breath. Sitting with my brother-in-law while he explained to their 3 young daughters, ages 7, 10, and 3, that Mummy went to the hospital last night while they were sleeping and she wouldn't be coming home. To Lynn. Holding the girls while they cried, knowing that there was nothing that any of us could do to ease their pain. Knowing that life would never be the same for them or for any of us. Her loss left such a huge gaping hole in all of our hearts. Through the darkness came a light, a sense of clarity. Seeing my niece's pain and anguish gave me the push I needed to make one of the most important decisions I've ever made. The decision to stop my cancer before it could even begin. Let me explain. When Krista was first diagnosed with breast cancer several years ago, I decided to get tested for the BRCA1 and BRCA2 genetic mutations. Like Krista, I tested positive, but I thought it was something I could deal with at a later time. I put it so far in my rearview mirror that the only time I really thought about it was when I was waiting for my most recent mammogram and MRI results. That's when the what-ifs entered my mind. However, as quickly as they would enter my mind, they also left when I would get the all-clear from my doctor. I didn't want to think about it or to talk about it. I felt fine. I didn't have cancer, and I was happy living life blissfully ignorant. I just felt that it was something that I could deal with later, if and when I had to. When Krista lost her battle with this terrible disease, I realized I needed to take some kind of action. I just didn't know where to begin. I was put in touch with Kelly Metcalf, who conducts research on the prevention and treatment of hereditary breast cancer at Women's College. I went to see her, and she became the driving force that helped me make the decision to move forward. Kelly asked me one very simple question that put everything into perspective. Even though I already knew what I needed to do to survive, coming from someone else, someone who didn't have a vested interest in my life or health, it sealed the deal for me. She asked, "What is the most important thing to you?" I cried, answering my family, my children, my husband, my parents, my siblings, and my nieces and nephews. At that point, I knew that I would do everything in my power to prevent what happened to my sister from ever happening to me. I refused to become a statistic. I refuse to become one of the 14 people that die each day from breast cancer, not if I can help it. I wouldn't let my husband bury his wife. I wouldn't let my children grow up without their mother. I wouldn't let my parents suffer the loss of another child. I wouldn't leave my sister sisterless. I wouldn't leave my nieces and nephews down another auntie. It's at this point that I decided to take my health into my own hands. One simple question that no one had asked me before changed the course of my future. After meeting with the surgeons, I made the decision to have a preventive double mastectomy at Women's College Hospital. It was a difficult procedure with several weeks of discomfort and recovery, but it was nothing compared to watching my sister fight and ultimately lose her battle with breast cancer, and now watching her children grow up without her. Today, as I stand before you, I can look at my 4-year-old son James and 2-year-old daughter Abigail and know with almost full certainty that I am safe from breast cancer. From the moment I decided to investigate my options, everyone at Women's College was extraordinarily helpful. They provided me with all of the information I could possibly need and took the time to really explain things to me. I felt like I was being taken care of every step of the way. Dr. Semple, my plastic surgeon, is just the warmest, nicest man. Dr. Still, my breast surgeon, was so supportive and caring. Their staff is incredible too. The day of my surgery, one of the residents came to walk me into the operating room. I was so overwhelmed with everything that I just started crying. That's when Dr. Semple actually came over and held my hand to comfort me. At one point, I had Dr. Sill and several nurses and OR staff rubbing my forehead, massaging my legs, and telling me everything was going to be okay. I felt so safe and looked after, which was exactly what I needed. Throughout my journey, my niece Brianna, Krista's oldest daughter, took a keen interest in women's college and their work to save the lives of women just like her mom. At just 10 years old, Brianna decided to host a spa day fundraiser in support of women's college. Can you believe that an amazing girl who is still struggling with the loss of her mom raised over $2,500 in just one day? She gives me so much hope for the future. In fact, it's my sincere hope that by the time Brianna and her sisters and my own daughter get to an age where they can even begin thinking about genetic testing, this type of breast cancer will be a thing of the past, that a preventive mastectomy won't even be necessary. We know there are no guarantees in life. There are very few ways to achieve 100% health, but by playing the odds and mitigating as much risk as possible, you can help eliminate your risk factors. For me, it was a preventive double mastectomy. As a BRCA1 carrier, your breast cancer risk is approximately 80%, or you can reduce your risk to 5% by having a double mastectomy. I will take 5% over 80% any day of the week. This is my new normal. I vowed to my sister that I would always be there for her girls. I promised to always be there for all of life's little moments, the ups and downs, when they need a hug or a shoulder to cry on, someone to do a happy dance with, or someone to help guide them in a straight line. I promised my sister that I would never let her daughters forget who she was or how much she loved them. I promised to talk about her all the time, even when it hurts too much. I will not break my promise. Women's College asked me to be here with you today to share my story so that you can see firsthand the effects of your generosity and support and how much it matters to people like me. I chose to speak here today so that I can say thank you. Your generosity and support has indirectly had a significant impact on my life and the lives of my family and friends, not to mention the countless lives that will be affected by the BRCA gene mutations and other types of cancers today, tomorrow, and every day after that, until we beat this disease once and for all. Thank you.
Sorry.
Thank you very much. Thank you, Kirby, for the courage to share that story with everyone. I hope you enjoyed yourself, and we'll see you again.